All right, welcome everyone. This is going to be the using FHIR Workflows to deliver personalized health experiences. And your presenter is Kyle Thompson. Just so you know, for those of you that are on Zoom, you are going to be putting any questions that you have in the Q&A box on Whova. And for those of you in person, we'll be waiting until the end of the presentation to take questions. It should be about 5 minutes left to do so. Kyle, are you ready?
Sure am.
All right.
Okay, thanks. Hello everyone, my name is Kyle Thompson, and today I will be telling you a little bit about how we used FHIR Workflows in a solution to a business problem that came up for us recently. Before we get started, let me first tell you a little bit about myself. I'm currently working as a data scientist for a company called League based out of Toronto. I've been with League for about 3 years now. I'll tell you some more about what League does exactly in just a moment, as it's relevant to what I want to present to you today. Prior to League, I worked at a digital pharmacy called PillPack, and I was there for, again, about 3 years. There's two main things on the agenda for today's talk. The first big thing I want to go through is I want to set up the system that came for us. And then after that, I will go through how FHIR Workflows into our solution to that business problem. At the end, I'll give a brief summary of what we talked about, and I will highlight some key items that I hope everybody was able to gather from the presentation that I'm giving today. So we'll start off by describing the business problem that's motivating this presentation. League is a digital health software company. Some of the big things that we do at League include gathering health data from our users. We ingest health data from our partners. Then we help our partners to build and deliver personalized digital health experiences. One of the main ways that we accomplish all of this is through a product we call Health Journeys. In Health Journey, help users identify and track any health goals they might have. As part of after this, using activities the user can work through in order to meet their health goals. A core component of Health Journeys are objects called campaigns. At League, we call a sequence of activities meant to help a user achieve a particular health goal or a set of health goals a campaign. We model campaigns using directed graphs. In these directed graphs are nodes, and these nodes represent specific things that need to be completed either by the user, our systems, providers, or their payer in order to work their way through the campaign. You'll notice that attached to some nodes are a list of activities. A key feature of campaign is that there's some choice in what activity to present the user to do as part of a node. For example, in node 1, we see activities A, B, and C making up group 1. We might only want to surface one activity to the user as part of node 1 in group 1. For example, activity A could be go for a run. Activity B could be asking the user to go for a swim, and activity C could be asking the user to go for a bike ride. We might not want to ask them to do all three. Rather, we want to pick the one that best works for that user. Connecting each of the nodes are directed edges. This defines the flow of the campaign. At other points in the campaign, you'll see branches. Branches allow us to specify different activities that the user could do based on how they're performing or how much they're benefiting from the campaign. So for example, if the campaign is to manage their blood pressure, by the time they reach the first branching node, if it turns out that their blood pressure is getting worse, then we might want to alter what we're recommending the user to do as part of this campaign. I'm sure a few of you can spot some natural data science problems that arise in health journeys and health campaigns. For one, Given a user's health data and health goals, which campaign should we recommend they go through? For example, if you want to manage your diabetes, there's many different ways you could do this. One is through managing your weight. Another is by adjusting your diet. Another is getting more exercise. A user only has finite amount of time, so which one should we get them to go through? At each node, there's often a choice to be made about which activity to get them to do. For example, should they go for a run or should they eat a salad? Finally, at branching nodes, there's often a choice about which branch to go down. Sometimes you can specify this branching logic. For example, you could say, take the top branch if the user's health is improving, take the bottom branch if it's not. Other times, things are a bit more ambiguous and a choice needs to be made. And this brings me to why I, as a data scientist, am so interested in FHIR. Well, one thing is I need a lot of data to build machine learning models. Another is that health data comes from many different sources, for example, EMR claims, etc. Historically speaking, all this data has come in different formats. Even claims data will come in all sorts of formats. Compounding to this issue is that we're adding new sources of data all the time. All of this means that I spend a lot of my time doing the thing I hate the most, which is just going through the data and cleaning it and just putting it into a consistent format. FHIR reduces this time significantly. By putting all the data into a standard format, it makes understanding and cleaning the data much easier for me. Okay, I think I've rambled on enough about the business problem motivating our use of FHIR. So let's move on to talk about how we're using FHIR in our solution. So it turns out that campaigns can be modeled as FHIR plan definitions pretty neatly. For one, actions within the plan definition can be used to describe nodes within our directed graph. We can use sub-actions within the plan definition actions to define the list of choices we have of the different activities that we can present the user. We can use the related action element within action to define the directed edges between the different nodes. And finally, we can use activity definitions to define what the user needs to do as part of, in order to complete a node. We can also use activity definitions to define what payers or providers or whatever they need to do in order to complete a node if that node is assigned to them. Okay, so how do we build these campaigns? Well, first of all, we don't want to rely on people like me to build these campaigns. Rather, we want to get experts who know what they're talking about to build these directed graphs. In order to do this, we provide them with third-party tools where they can define who the campaign is for, the different actions within a node, including different options available to include in the node. And if they need, they can also define branching logic. Upon publishing the campaign, our systems take the output of these third-party tools and we generate a FHIR plan definition from them, which we then send to our FHIR server. Now that the subject matter expert has created this directed graph and we have this plan definition, we're in a good spot because a plan definition can be used by a computer to identify different activities that a user can do as part of a campaign. So the next step is we want to apply these plan definitions to a user. So when a user enrolls in a campaign, and as they work on a campaign, we'll be repeatedly applying the plan definition to them. An output of this process is a FHIR workflow. As we apply the plan definition, we use the user's health data, any of their health goals, and any other data we have on them to pick relevant activities for them, along with a path through the plan definition. I've included a diagram on the bottom, which just shows a possible path and possible activities that could be picked for the user as part of the campaign. They're all highlighted in green. If branching logic is specified, then the user will work through activities until they hit that branching node. And then we won't compute any activities for them to do beyond that. We'll wait for the user to reach that point and then evaluate the branching logic that's defined at that node before determining how to proceed beyond it. So let's take a closer look at the FHIR workflows that are generated as part of this process. So the green nodes of the directed graph are represented using a set of requests and tasks, and requests and tasks are paired off. The requests are used to ask the user to do something, and the tasks are used to track the user's progress against the request. Red boxes represent the request groups. These are collections of requests. Request groups are very important because they capture the ordering and timing between the different nodes. And finally, all of it comes together under a care plan. And at the highest level, the care plan is used to represent the campaign. Activities within the care plan are the request groups themselves. Here is another view of the FHIR workflow that we generate as part of the campaign. All these resources are generated as an output of the apply operation on the plan definition for the user. All the requests that are generated are on the left-hand side of this diagram, and all the tasks that are assigned to the user or the provider or whoever, they are the blue tasks that you see on the right-hand side. Now, this all conforms to the core FHIR spec as it had everything that we needed, and we didn't really need to extend beyond what was already there, which is really great when it comes to the implementation guide. It means that we don't have to add anything for these resources. Now, one last thing I want to highlight is that these FHIR workflows can be published in a draft state. We don't have to present them to the user as soon as they're created. What we can do is we can actually send the resources we create, the campaign that we create, to an expert like the user's doctor to review and modify before we actually send it to the user to action on. This gives us one last way to give a sanity check before asking the user to do anything. Now, because we're doing everything in FHIR, we can pretty easily send the campaigns that we generate over to the expert for them to review. Okay, so this brings us to the end of my talk today. I want to wrap things up by highlighting a few key points that I hope everybody was able to take away from the presentation today. The first thing is that FHIR plan definitions are excellent for modeling directed graphs representing sequences of activities with choices. We can then use machine learning to help identify some of the best activities for the user to do from the set of choices presented within the plan definition. The second thing I want to highlight is that FHIR workflows can be used to build and deliver personalized health experiences. And finally, FHIR standardizes the data collection process. This reduces the amount of time that is spent just trying to understand the data that we have and cleaning it into a consistent format that is useful when we're building these machine learning models that I described in the first point to personalize campaigns. FHIR also allows us to share the workflows we create with our partners easily so that they can give input if they so desire. Here's a list of my contact information. You can reach me over the Whova app over the remainder of the conference. During the after the conference, you can also reach me at the email address provided, as well as on Zulip. I just want to thank everybody for coming to my talk today, and if anybody has any questions, I'm more than happy to take them now. Thanks.
All right, so if we have any questions, we can take them. So I don't see anything in the Q&A chat box yet for Huba. So is anybody on site wanting to ask Kyle a question? Well, we're waiting to see if anyone on site does. We just got a question in Huba. How can such a workflow be modeled with decision support algos? Algorithms, maybe?
So the plan definitions are created by like clinicians, or like they're not only meant for clinicians, but insurance providers, insurance companies can also create them when they're to communicate and work with their users, their customers. So they kind of specify the framework for the care that's to be delivered, or the service that's to be delivered. And so at each node, they might say something like, "Oh, today the patient needs to get cardio. They need to get their cardio in, or they might need to do some exercises as part of some therapy." But in a way, it doesn't really matter what they do. So they can say like, "Oh, they could do this cardio, or they could do this cardio." And then what we want to do is we want to find the things and present the things that people are likely to do. People love thinking about themselves. They spend a lot of time thinking about themselves, and by presenting them things that are tailored for them, they're more likely to engage in it and stay engaged in the care plan that's put together for them. So that's our goal. It's not to replace the clinician, but it's to help them keep their patients engaged, or keep their customers engaged in the process and keep them moving.
All right, thanks, Kyle. Are there any other questions? Anybody on site have a question?
Hi. I have a question about how the machine learning part works. How do you seed the data from the start, and how do you get to kind of the right care plan for the right patient?
So the right care plan for the patient and seeding the different activities, they're two separate problems. I'll start with the second one. So what we do is we start off with a very constrained version of the plan definition to start with, and then slowly add activities over time as we see what users engage with. We could also present them with different like two different users could get two different versions of the care plan, just so we can learn and get diversity over what activities people see. So that's how we do that part. In terms of recommending which care plans, it's really looking at what kind of content the user typically engages in. So for that, there's the big approach that we use is just like collaborative filtering techniques. Like, what is this user engaged in the past? What are people like them engaging in? Now we make sure that there's people who like experts that are in the loop all the time, so that we're not recommending insensitive things or inappropriate things to the user. So yeah, I mean, the cold start problem in terms of recommending what content somebody is likely to engage with, that's a bit trickier. And a lot of times that's a lot more prescriptive in the beginning.
All right, thanks, Kyle. I think we're at time right now. So that was perfect way to end. If anyone does have any further questions, you are welcome to put them in the chat box or the chat or Q&A box for the using FHIR Workflows to deliver personalized help. And Kyle will be monitoring it over the next few days. So thank you again, Kyle, for the excellent session. And thank you to our attendees in person and online. And we hope you enjoy the rest of your day.
Thanks, everyone.